we found was that all of the patients had recurrent UTIs before the fecal microbiome transplant. That's how we identified them.
Hmm.
But none of them met the criteria for recurrent UTI after.
Dr. Glenn Wernberg is a physician scientist with a special interest in improving the pathophysiologic understanding and management of urologic infection and other functional urologic conditions. He received his MD and his PhD in molecular genetics and microbiology, and his fellowship is in Neuro-Urology and Pelvic Reconstruction. Thanks for joining me today to answer questions submitted by our audience.
Great to be here. Thanks for having me, Melissa.
We have questions on quite a broad range of topics, but I'd love to hear more about your professional background and some insights about how you came to be working in this area of research.
Thanks, Melissa. Exactly right. So, I did my MD and PhD on Long Island at Stony Brook, close to home, and then my residency in urology at Cleveland Clinic in Ohio, and then my fellowship in neuro-urology and pelvic reconstruction, also known as urogynecology and reconstructive pelvic surgery at University of Michigan. And now I'll be returning home to Stony Brook. I'll be working, I'll have clinical activities and research activities. We'll have a lab there and be opening our clinic very soon this fall. So we're excited about that.
Yeah, it's great to hear that you're opening a clinic. There's always a need for patients in our community, especially to find clinicians with a special interest in this space. And there aren't that many of them, despite the prevalence of the problem. I want to cover a topic that we often cover on this channel, but I think it's always worth going into again, and that is UTI testing. Standard urine culture, we know it's a bit unreliable, but how unreliable is it and what can it miss?
Well, standard urine culture has some challenges associated with it. First and foremost, it takes about 3 days from the time a urine culture is drawn to the time for the final results of antibiotic susceptibility testing. So during that 3-day window, a number of decisions have to be made. Often patients are treated empirically with an antibiotic, but uh, very commonly that antibiotic needs to be changed based on those final culture results. And in the case when the patient has inadequate or incomplete coverage based on that antibiotic, those patients go on and have symptoms for additional days. And this can be 3, 4 days until they get on the appropriate antibiotic. So that's the first issue, is that it takes a long time. It also can miss things. It can come back as contamination, wherein multiple organisms are identified, and often these patients don't receive treatment because the idea is that the culture itself is non-definitive, and maybe a repeat culture is drawn, and maybe that culture also comes back as contaminated. So these are issues with the urine culture. It's also possible that that urine culture would be negative. The patient has recurrent symptoms that are consistent with a urinary tract infection. So
Mhm.
uh, these are the challenges.
There are quite a few, and patients often report the things that you have said, negative cultures in spite of their symptoms, and then also the contamination, where it could be a polymicrobial infection. So there's a lot of discussion in the patient community about that. And there are more advanced testing technologies available, such as sequencing, next generation sequencing or PCR, that can detect bacteria that standard culture misses. And why do you think these are not being used clinically yet?
Well, they're starting to be used more clinically, but historically, and even now, the challenge with those is that these technologies will pick up bacteria that are not necessarily alive in the urinary tract and are not necessarily causing an infection. They can be, but in some cases, they may also be detecting DNA from old bacteria, maybe from infection in the past, or maybe from bacteria that could be protective against UTI. So the challenge there is that they're very, very sensitive. They'll pick up any bacteria that are present or were present in the urinary tract, but also not particularly specific for urinary tract infection. So in the future, I believe some iterations of these technologies will become very, very important. We're seeing that already. Some combinations of the molecular testing with some of the classic points of the culture, which are helpful, I believe implementation of some of the good points of the molecular testing and the standard culture will wind up being the future of diagnostics in UTI.
That's a question that comes up quite a bit. These new technologies can detect all sorts of organisms. Should a patient be treated for asymptomatic bacteria when the symptoms are there, but I mean, there's no symptoms, but there are bacteria found? Do you think patients should be treated in that case?
Generally, the answer is no. So if somebody has no symptoms, but for whatever reason they've had a urine culture and this urine culture shows up as growing some organism, typically treatment's not indicated for that patient. Now, there are a couple of exceptions to that rule, like there are exceptions to every rule.
Hmm.
List a couple of them, but of course we treat all of these as a case by case basis. You have to look at the whole patient, first of all.
Hmm.
But the two notable exceptions are in pregnancy and prior to a subset of urologic procedures. Those are the cases where we do routinely treat asymptomatic bacteriuria.
Can you talk a little bit more about why that's the case in pregnancy?
Well, having a urinary tract infection can be a higher risk for the patient and the fetus. So, um, identifying an early or urinary tract infection or a potential early urinary tract infection allows for rapid and efficient treatment. So that's the main goal there. There's also some immunocompromisation associated with pregnancy. So um, that's typically why we address asymptomatic bacteriuria differently in that population.
Okay. Do you think there are certain patients who might benefit most from advanced sequencing technology for UTI testing?
We're learning more about that now. Some of those patients are the ones that I had just described, where we do treat the asymptomatic
Hmm.
bacteriuria. Also, prior to a urologic surgery, for example, if somebody's having upper tract manipulation or prior to having a urologic implant, for example, these
Hmm.
technologies can be very important because it makes sense to have a very highly sensitive study so that bacteria can be completely cleared and eradicated from the urinary tract prior to such an intervention. So that's one case. Other cases are patients with recurrent contamination, cultures that read commonly as contaminated, maybe. There's polymicrobial activity, which are related to infection. So
Hmm.
this population may also be perhaps well served by these molecular-based tests. Now we're learning more about these, and by that I mean we're starting longitudinal clinical studies. We're starting clinical trials to better assess what are the
Hmm.
populations that would benefit most from diagnoses based on these technologies.
It would be interesting to see the results of those trials. Are you currently using any of those technologies in your practice?
Currently, we're not. We're working on implementation of these
Hmm.
technologies now. So, like anything, these are changing rapidly and they're improving rapidly. So we're very interested in some of them and
Hmm.
very interested to the point that we're working closely with our industry partners to identify how to implement them safely, how to identify the patients in whom we should be implementing them, and and the other areas associated with implementing a new technology in a hospital system, particularly a large hospital system. So we're working on that. The next few months, hopefully, we'll be able to offer these to a subset of patients.
Okay, yeah, it'll be great to see the outcomes of that work. I
Uh,
also want to talk about catheters, biofilms, and catheter-associated UTI. What is actually happening on the surface of a urinary catheter after it's inserted, and why does that matter for patients who use them long term?
Catheters um, can serve as a nidus for infection. But whether or not they are associated with infection, we know that there's biofilm that gets deposited on these catheters. And we know it gets deposited very early on after catheterization. So,
Hmm.
studies by my group and others have demonstrated that even just hours after catheterization, some biofilm can be detected on these catheters. And what do we mean by biofilm? Biofilm are bacterial communities that are adherent to one another and to a surface, such as a
Hmm.
catheter. And they can protect the bacteria from the immune system and from antibiotics. So you get biofilm deposition early on. You get it on some particular parts of the catheter, and then it can progress fairly quickly. So after about 3 weeks, you see a very large amount of biofilm deposition throughout the catheter. And it sort of makes sense because clinically, we aim to change our catheters about once monthly or more
Hmm.
frequently. Varies patient by patient, but it does seem to correlate with biofilm deposition as well.
Given how quickly that happens, how likely is it that someone who does use a catheter or an indwelling catheter can avoid recurrent infection?
Well, as I said, people with catheters are subject to recurrent infection. They have a higher risk for infection than the general population. We have strategies to prevent infection, but even so, there's a 3 to 8% risk of bacteriuria per day of catheter indwelling time. So not necessarily 3 to 8% risk of urinary tract
Hmm.
infection, but we know that bacteria will wind up in the urinary tract in patients who have catheters. So how to prevent infection is the goal, not to
Hmm.
prevent any bacteria from entering the
Right.
urinary tract. It's going to happen. So how to prevent that transition from colonization to infection? That's the goal for patients with catheters. And we have a number of strategies to be able to do that.
Can you talk us through some of those?
Yeah, so there are, and it depends on the patient. So it depends if a patient has a catheter and never has recurrent UTI, or they
Hmm.
have a rare UTI. So we're not going to escalate treatment or ex escalate prophylaxis in that case.
Hmm.
But patients who have recurrent infections with a catheter, there are a number of strategies to be able to deal with that. One of which would be a urinary antiseptic, essentially clearing bacteria from the urinary tract. This can be taken on a daily basis, something like methenamine hippurate
Hmm.
or Hiprex. We have a number of behavioral and conservative considerations that we can provide patients. Um, ase Aseptic insertion technique of the catheter, some teaching that we can provide. And again, we look at the situation as a whole, so difficult to give the laundry list of what we can offer. Typically, we talk to the patient, get a good understanding of their
Hmm.
history, look at their infection history, their microbiology history, and we go from there.
We do get quite a few questions about catheter use and whether Hippurx is an appropriate prophylaxis. So it's good to hear that you do use that in practice.
In a subset of patients with catheters.
Right. So when a urine culture comes back saying E. coli in a sample provided by a catheter user, is that the whole story, or could something else be missed?
Well, it depends a little bit. So if it's E. coli and somebody has symptoms associated with infection, and again, patients with catheters are presumably not voiding, so you
Mm,
can't talk about things like pain when they
right.
urinate or urinary frequency or urgency. So it's a different constellation of symptoms. So those symptoms might be suprapubic pain or in some more severe cases, flank pain or fever or something like
Hmm.
this. Autonomic dysreflexia or differences in autonomic dysreflexia for patients who have had a spinal cord injury, for example. So these patients, if E. coli is grown and no other organisms are grown and they respond well to treatment, then perhaps that's the end of the story. But
Hmm.
I think what you're getting to is, can there be other bacteria at play there? And perhaps yes. Again, considered on a case-by-case basis. And how did the E. coli overgrow, if you will, in the first place? Is there a community of bacteria that's protective against an
Hmm.
infectious bacterium? And has that been changed in some way? Is there a dysbiosis of the urinary tract? And how can we target that? So we don't know the answers to some of those things that I'm putting out there, but those are things that we're
Hmm.
looking into in the lab and trying to be able to answer that question. How does the overall community structure of bacteria in the urinary tract and surrounding anatomical niches, how does that protect against urinary tract infection? How can changes in that increase the risk for urinary tract infection?
It's a really interesting question, and patients have been asking that for a long time. Like, how can we protect, but also how can we replenish after antibiotics? And I think that's a really important area of research from the patient perspective. It's probably a good
Yes.
time to talk about bacterial interference as well. Can you explain what that means and how it could be beneficial for a catheter user?
Yeah, so bacterial interference is the concept that a bacteria can outcompete another bacteria. And so that's the general principle. But the idea as it applies to recurrent UTI is, can bacteria that don't cause disease in humans protect the urinary tract from bacteria that do cause
Mm-hmm.
urinary tract infection in humans? So can we implement or can we induce colonization of the urinary tract with a commensal bacterium, something that's not going to cause symptoms or not going to cause urinary tract infection? Can that outcompete a detrimental bacterium like E. coli, as you mentioned earlier? So E. coli, some strains of E. coli, by the way, can be commensal and
Mm-hmm.
perhaps protective, and others, of course, we know are uropathogenic. So can one strain outcompete the other? That's the idea. There are some lines of evidence that support this in a number of disease models, a number of different organs
Mm-hmm.
in clinical studies as well. So there's a lot of interest behind this as well in urinary tract infection.
Has it been demonstrated successfully yet?
Yeah, in the experimental context, it has.
Mm-hmm.
Many are interested in implementing clinical trials of things like this, inducing colonization of the urinary tract to outcompete
Mm-hmm.
uropathogens. Some of these are ongoing or very close to recruiting, and I think that that's a really exciting opportunity.
How are the beneficial organisms delivered to the bladder in that case? Is it via a catheter or are they taken orally or vaginally?
Any of the above are possible.
Hmm.
They can be introduced via a catheter in a number of different ways. The key is to be able to induce colonization that isn't just transient. So if you induce a colonization of the bladder with something that will just be gone a few hours later, then that really hasn't changed anything. So the goal is to optimize the delivery system. In such a way that allows the urinary tract to remain colonized with that protective
Hmm.
bacteria.
Earlier in the interview, you mentioned this window between waiting for standard culture results and potentially prescribing antibiotics. Do you think there's a better way to handle that window, given that sometimes patients will then be changed to a different antibiotic once the results have returned?
Yeah, it's a challenge. Some practices are to wait for that final culture result. This is a problem because on the patient side, those patients have
Hmm.
persistent symptoms for 3 days.
Yeah,
So this is not ideal.
agreed.
So particularly for patients who know very well when they have a urinary tract infection, to
Hmm.
request that they wait for that final culture is really suboptimal to say the least. Now, that being said, it's also suboptimal to prescribe an antibiotic that doesn't work. So
Right.
how do we get around that? Well, probably the answer will lie in a combination of the microbiological history
Hmm.
and number of patient factors. So there's a lot of efforts into using AI to integrate all of those data and make a very good prediction early on for what would be the best antibiotic, or what's the likelihood that a given antibiotic is resistant or sensitive, or rather the likelihood an organism that will grow on the culture is resistant or sensitive to a given antibiotic. So my group has done some of this, and we've been
Hmm.
able to demonstrate that we have a series of algorithms that are accurately able to make these predictions. So lots of efforts ongoing, lots of interest in these, and we're interested in implementing them so that we could optimize precision therapy for patients early on and not have to wait for 3 days for that final urine culture result.
Would that be then based on a point of care test or looking at symptoms in the patient and their history and then coming up with a solution?
It could be both. So in the studies we've published, we've looked at the history
Hmm.
and labs and microbiological history, demographics of the patient, different other factors as well, and we've integrated all those. In some cases, together with urinalysis, that's
Hmm.
available within a few hours, and we've developed the algorithms based on those. That being said, can you implement a point of care test as well? In addition to the urinalysis, for example, one of these molecular-based testing
Hmm.
diagnostics into such algorithms, that's an opportunity for the future and perhaps a strong way forward as well.
Yeah, there do seem to be many different companies and researchers working on point of care tests for UTI, and it will be interesting to see which ones actually make it into clinical practice and how that changes patient outcomes.
Absolutely.
So we've talked briefly about the beneficial bacteria. Is there a connection between gut health and UTI, and what is the evidence for that?
Yeah, so the idea is that there is a gut urinary tract axis. There's a lot of work in animal models that supports that there is a correlation between the
Hmm.
gut urinary tract flora and microbiology. And we're learning about how that's important for recurrent UTI and how we can leverage our understanding of how these relate to preventing UTI. Um, so in the animal models, what we can see is that prior to a urinary tract infection, often there's a bloom of bacteria in the gut, and the bloom
Hmm.
of bacteria can be a particular uropathogen just prior to UTI. How that correlates to humans and whether these are related and causative in the animal models are not yet known. So we're looking at that very carefully experimentally in the lab. There are also some clinical studies that demonstrate that isolates from the urinary tract in the context of urinary tract infection are very similar to strains that can colonize the gut.
Hmm.
So we have lots of interesting evidence, but we're experimentally trying to understand how we can leverage these insights into improving the care of our patients.
There's a lot of anecdotal evidence in the patient community about this as well. We often hear patients describe improved UTI symptoms when their gut health improves, or vice versa, especially after taking multiple rounds of antibiotics when their gut health seems to have been diminished, and then they seem to get more UTI. So we hear these kinds of experiences all the time. And that is one of the topics that comes up a lot, the gut health and then related potential therapies. And one of those is fecal matter transfer. And I know that you've done research into this yourself in the context of UTI. Can you tell us about what you found?
Yeah, so I agree. The idea of improving the bacterial communities in the gut to improve the urinary tract health is was the goal here. So
Hmm.
what we did was we leveraged an ongoing database of patients who had Clostridioides difficile colitis, C. diff colitis.
Hmm.
And what we did was we found a subset of the patients, and this was all retrospective. So there are the caveats associated with the retrospective analysis.
Hmm.
We found a subset of patients who had recurrent urinary tract infection, and we looked at their recurrent UTIs before and after a fecal microbiota transplant. And the results were very, very interesting, and there was a strong signal. So what we found was that all of the patients had recurrent UTIs before the fecal microbiota transplant. That's how we identified them.
Hmm.
But none of them met the criteria for recurrent UTI after the fecal microbiota transplant, in 2 years after a fecal microbiota transplant. So this is a really impressive finding. However, again, this was retrospective.
Hmm.
All of the patients also had C. diff colitis, recurrent C. diff colitis. So we don't know how it's generalizable to patients who don't have
Right.
that condition as well. It was a small study. Our subset of patients was only 10 or 12 patients who had met the criteria.
Hmm.
So that being said, it's an exciting opportunity for better study, an exciting way forward clinically to start things like longitudinal trials
Hmm.
for patients who have recurrent UTI, and even if they don't have C. diff colitis, to understand the safety and efficacy of fecal microbiota transplant for protection against UTI. So that's an interest of mine, interest in for others in the field as well. So we're working to be able to conduct such a longitudinal
Hmm.
study and ultimately a clinical trial safely. So working through some of the regulatory parameters associated with this now.
I think there will be interest in our community in a trial like that, so we could probably help recruit when you do get to that point. There
That
are a
would be
few
fantastic.
questions about how FMT works. How do you source the fecal matter and make sure that it's safe for transfer?
So a number of different ways have been described over time, and these have changed even in the recent years. Changed a little bit based on the COVID pandemic, also
Hmm.
because regulations have changed in terms of donor and things like this. But some of the ones that have been described are choosing a donor patient. So the recipient or the proposed recipient would choose a donor. The donor would provide the specimen, and the specimen would be given to the patient
Hmm.
either colonoscopically or orally. So that was sort of a traditional way. There
Hmm.
are other mechanisms, some of which are commercially available. So in some of these, they've been screened carefully, purified, ensured for safety, ensured that they don't contain any adverse viruses.
Hmm.
And these are now commercially available. They can be taken via the oral route. They can be given via suppository or via enema. So there are multiple options in terms of fecal microbiota transplant. Of course, some are of more interest, I would think, to a patient than others. Again, these are some of these novel mechanisms or
Hmm.
things that have been completely purified. Only a subset of bacteria are present and can be encapsulated, things like this. So it's becoming a situation where it's um, close to being better access,
Hmm.
a better accessible formulation, and we're getting there. So hopefully we'll be able to choose a formulation which has maximum efficacy, but also maximum interest of patients who would perhaps benefit from it.
It is important to talk to patients about how they would be willing to have this type of treatment administered. But we have heard from patients in the community who have sought this out privately and done FMT and found it beneficial. Do you think it's at the point where, for people who could access it, it would be worth trying?
Well, on the clinical side, we are working to start to be able to do this on an experimental basis. So, it's very important to understand the safety of these new technologies in the population in whom they're going to be used. So that's where we are
Hmm.
now. I'm not going to recommend that people try it at home if they
Yeah.
have access to it. I mean, from our perspective, we really need to look carefully at the safety and efficacy. And then if these are clear signals and they're safe and effective, well, then this is fantastic because then
Hmm.
we have another modality that we can offer our patients.
What are the potential side effects or safety concerns of FMT?
Well, there's the risk of transmission of some viruses or diseases that a donor might have if they're given colonoscopically. All of the
Hmm.
same risks that are associated with colonoscopy would be associated with fecal microbiota transplant. There's a risk that it just doesn't work at all.
Hmm.
So a risk that there would be a major financial burden to a patient with little or no efficacy, so that's a risk as well, and others. So that's why we do the studies. That's why are interested in comparing it to a placebo control
Hmm.
group of patients and getting a good sense of how effective this really is.
It will be interesting. We have heard from a patient or two who have tried it at home as well. And some of the side effects that people have reported, whether they do it themselves or at a clinic, are like gut upset, basically, gastrointestinal symptoms, which I assume is not uncommon when you transplanted a new microbial community into someone's gut. But it will be interesting to see the results of this research because, like I said, there is quite a bit of interest, and patients are very happy to do something that's non-antibiotic, especially when antibiotics have not resolved the problem for them. And that is one question I wanted to ask you. What other non-antibiotic options are furthest along in terms of looking promising for recurrent UTI treatment?
We have a number of different treatments that can be effective, or rather, I shouldn't say treatments, but prophylactic regimens that can be effective. And there's good
Hmm.
evidence for some types of cranberry, not all of them. There's good evidence for methenamine hippurate or
Hmm.
Hiprex. We now have a randomized controlled clinical trial that shows efficacy for this, and a number of other non-antibiotic agents. So typically, we try to start with prophylaxis using non-antibiotics. And then in a subset of patients who are still having recurrent UTI, then we start considering things like antibiotic prophylaxis. The risk there is selection for additional antibiotic resistance. What we don't want is to have a patient who a few years down the line is resistant to all of the oral options and then requires either a PICC line or hospitalization
Mm.
to get the antibiotic that they need for their urinary tract infections. That's why we try to avoid um, antibiotic prophylaxis routinely.
Right. And I think it's important for clinicians to have knowledge of these different approaches, especially for patients who don't want to take more antibiotics or who've had problems with antibiotics in the past. And it's good news to hear that you're opening a clinic in the near future for complex UTI cases on Long Island, as you mentioned. So, what types of patients do you anticipate seeing?
So we anticipate seeing patients with recurrent urinary tract infection who feel exhausted by their options. So they've gone to different providers, still having recurrent urinary tract infections. Um, we're interested in seeing patients who have some degree of diagnostic uncertainty. Perhaps it's unclear if they have urinary tract infection or another condition with symptomatic overlap, like interstitial cystitis, or even in some cases of overactive bladder, there can be overlapping symptomatology. So people who have complex situations, complex urinary tract infection, whether or not they have a catheter, whether or not they have some degree of immunocompromisation or urinary tract reconstruction history,
Mhm.
these are the types of patients who we'll be seeing.
That's exactly what the next question was about. A lot of patients have been to many different doctors at this point, and they will want to know what will be different about your practice that they haven't seen before.
Well, by definition, our practice will be interdisciplinary. So, for one thing, they'll have the opportunity to, if it's indicated, they could see an infectious disease
Hmm.
physician and a neurourologist or urologist with subspecialization or interest in urinary tract infection in the same day. So this is a unique opportunity. There are other, important aspects like we'll be performing all of the urine analyses, and that includes urinalysis and culture and any other diagnostics from the specimen that we retrieve in the clinic, and we'll
Hmm.
have a close degree of oversight of how that's processed and which diagnostic modalities are used for a given specimen. And of course, we'll have available all of the currently approved prophylactic strategies. We'll be working on implementing clinical trials, so we'll be able to
Hmm.
offer different experimental trial protocols for patients who are interested in being participants in such trials. And that will be really our starting point. And from there, we'll be working to be able to implement other therapies as well. The other side of things is that I'll also have a laboratory component to my practice. So I'll be
Hmm.
developing a lab, so there'll be a nice seamless integration between clinical care and the ability for patients to be participants in longitudinal studies wherein we're better understanding the pathophysiology of infection, and then hopefully being able to bring those insights from the lab back into clinic so that we
Hmm.
can help all of the patients very broadly to prevent and adequately treat these infections.
That combination of practice and research is really great. I think patients in our community in particular are very interested in participating in research so that we can try to move things forward for themselves or future patients. And also the multidisciplinary approach. We get messages from patients often asking if we can refer them to an infectious diseases specialist or a different type of specialist. And they have to manage this themselves usually by trying to find people who will work together or to try to put the information together as the patient. That's really exhausting and it can be difficult and sometimes impossible. And so it's good to see that you'll have these people under one roof so that patients can potentially see them at the same time.
Absolutely. I mean, the patient experience is so important because these patients have already seen many providers. They've dealt with all of the disconnect associated
Mm,
with from one specialty to the next. So these are all important, and as we're building this from the ground up, all of them are being considered. The other consideration is accessibility of the clinics, making sure that the
mm,
clinics are accessible to patients, in all sorts of ambulatory status,
mm.
whether they're in a chair or not. The ability for them to access this in a routine way, in a seamless way, are all important.
Yeah, crucial. And will patients be able to self-refer to your clinic or will they need a referral from a primary care doctor?
It depends a bit on insurance
Hmm.
status. We've got a team who would look at that carefully with the patient and be able to make that assessment. So some different insurers would require a referral, some would not. But those are things that would be considered and discussed with the patient.
Okay. And do you think you'll be able to serve patients outside Long Island?
Yeah, absolutely. So this can be done virtually.
Hmm.
In the United States, there's a bit of a consideration associated with billing if a patient is outside of the state, so outside of New York. So New York would be no issue virtually, but outside of New York, that would need to be discussed prior. So there are opportunities to do this. Certainly self referral and self pay for a counseling visit would be an option. Of course, not the
Hmm.
best option, but something that certainly we could offer early on. But we're looking at different ways to being able to make what we have as accessible as possible to patients around the U.S. and around the world, so that we can offer those additional opinions and be able to really get these patients on the proper track to recovery and adequate prophylaxis and get them hopefully as close to UTI free as possible.
Sounds good. And how can patients get in touch if they'd like to learn more or make an appointment?
So certainly they can find the link and the information that will be associated with this interview, and our website is stonybrookmedicine.edu. They can work to schedule an appointment with us through that, and we look forward to seeing them.
Great. I'll make sure the link is in the video description.
Thanks.
Thanks so much again for sharing your time, and I look forward to hearing more about the clinic and your research.
Thanks so much, Melissa. It's been great to be here.
Thanks so much for watching. I hope you found this expert video helpful. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveUTIfree.com for related articles. We'll drop some links in the video description. If you like what we're doing on this channel, you can support our work by hitting subscribe here on YouTube, and don't forget to tick the bell so you'll be notified of our future videos. Thanks again for watching, and until next time, keep asking questions and pushing for better solutions.